effects of experiencing teenage birth. Okay. Teenagers would think that they know about infectious diseases that are associated with sex or with having sex are 25% less likely to become teenage moms than those who claim that they lack such knowledge. So the importance of knowledge about sex and is about 25% less. So the more information that they have about sex, they are less likely to be teenage moms. Okay, so that's one very important finding, I think, that has many implications. So for the other two variables that were significant, when any form of contraception or protection from STIs was used by a young woman or her partner during her first sex, the likelihood of experiencing teenage childbearing is 34% lower compared to non-users of contraceptives or STI protection. Again, these are net of the effects of the variables that are included in the model. And then teenagers in poor households are 46% more likely to become teenage mothers than non-poor counterparts. Okay, so these are all net effects already. So conclusion. Apparently, young women's knowledge about STIs and use of protection during their sexual initiation are significant deterrents of teenage childbearing, and that poor household economic condition and having been in a marital union engender childbearing during teenage years. Well, these are just quick recommendations based on the very short findings that were found. So provision of correct information of STIs and use of protection during sexual initiation of teenagers, in particular. DepEd has been identified to provide comprehensive sexuality education, but for those only in formal schools. Okay? So, but then the IRR of the RPRH law, which requires comprehensive sexuality education for young people, has not really been used well because there are still many teachers who have not been trained yet. So I think they really need to push through and cover as many teachers as possible so that correct information can be disseminated. And expanded training as well beyond DepEd formal education use of the CSE modules to include as well other institutions like CSOs, NGOs, DSWD, DOH, if in some of the RHUs as well probably, to cover a wider range of teenagers that are not in the formal education structure. And then address teenagers' unmet need for contraceptives and STI protection, especially those who are already in marital unions. They may be teenagers, but if they're already in marital unions, they're married, or whether they are already in live-in arrangements, there should be access of these teenagers for protection from STI, and especially for also those who are disadvantaged economically.
Okay.
I think that's it. Thank you.
Thank you, Dr. Amelia, for your great talk. We are now open for the questions. If you have...
Siya na ba yung last sa program? Meron pa. Isa pa speaker.
Yes, ma'am.
So, yan din.
Good afternoon once again. I'm Teresita Talosa. I'm
of allowed
Richard, di ba
stakeholders.
lahat yung mga yan?
Since the focus of the government is to offer protection to our teenagers, since it seems anyway they will do it.
Researchers, no?
And just thinking,
Professors.
if that inquiry says we have this NGO that goes around the schools, high schools, and offer condoms to students. Of course, they communicate well with the school heads. My take this is that has the government and the academic institutions
Ano naman siya? Matanong siya.
given up on
At least
given up on our youth? Because if we offer them contraceptives, then that means to
Mukhang may
say,
hugot siya.
sorry, we have to accept that nagumuhot na yung ating moral values. Hindi po pa nakakalungkot yun. I mean, is the government not thinking of a way to offer
Against siya sa
a course in high school that will promote moral values among our students? Kasi if we offer them contraceptives, that means to say, nag-give up na tayo sa kanila. Well,
baka kasi malamang
admittedly, social media has a big influence on our children. Ang nakakalungkot lang po kasi, inaaral natin yung mga data, and we have those findings and recommendations. Pero anong ginagawa ng gobyerno? Wala pa siyang balak na mag-offer. I mean, hanggang yun lang ho pang science course, reproductive health ang kaya natin gawin sa academic institution. Pag-aralan lang, how does one get pregnant? Naniniwala pa rin ako kasi na may malaking magagawa ang social science research at ang ating gobyerno para maitaas pa ang moral values ng ating mga estudyante. Kasi kung ang tingin mo natin sa kanila ay nagkukulis naman sila in days of 15 to 19. So, ibig sabihin, nasaan na yung hope natin na sinasabi natin? Parang ang hirap na makita kung reactive na lang ho tayo sa sitwasyon. I'm sorry. I'm very to get emotional about this. Pero yun naman ang gusto kong i-express. Ang dami-dami po natin academicians dito. Ang dami-dami po natin researchers. Pero parang hanggang reproductive health bill na lang po bang solusyon natin? Hindi ang itaas ang moral values ng ating mga youth. Yun lang po. Thank you.
Meron po bang talagang
sa IG kasi nalaman pa din sa Uy. Oo. Alam ko ginawa ko.
This is just a reaction because as I've been a teacher for 4 years for high school, for a public high school, so I kind of understand what Matt was going through. But with regards to addressing the problem on teenage pregnancy, it's much more complicated than that. And I understand that there is importance in valuing, as you have mentioned in your slide before, the comprehensive sexuality education. I think we have to really push for that and have an open discourse towards a positive way of looking at sex and making the youth understand the implications of their actions, but because it will, the morality side of it is, I don't know, I don't think it's that easy to kind of address. But from my observations as a teacher for 4 years, I see a lot of these things happen. I have students before, I'm gonna be in detail with that, but poverty, as what Huda has mentioned before, is a factor that actually kind of makes them more susceptible to not just teenage pregnancy, but also a lot of STIs and HIV and whatnot.
Actually, I have been going around as well as part of a team, conducting adolescent reproductive health trainings for guidance counselors. And even guidance counselors find it difficult to discuss the topic. And so they always underscore that even parents have difficulty discussing the topic. So where do we go? So I think that comprehensive sexuality education that is being recommended under the RPRH law actually should require not only RH but also moral issues and relationships. The youth should know what getting into a relationship should mean and to what extent they can do within certain relationships. And how to deal with them is a very important part of the sexuality education that is being developed. And from what I heard, there is already developed modules in comprehensive sexuality education, but the fact is not all or very few have been trained on this. So it's not being pushed yet by the Department of Education, which is expected to implement the CSE. So that's why I put in there for push for DepEd to do what they're expected to do, and then for greater coverage of teenagers, there should be involvement as well of other concerned institutions like NGOs and CSOs as well. But then Ma'am mentioned that about the condom distribution. I think that's a DOH policy. The earlier DOH administration, but then during the trainings that we conduct for guidance counselors, they were saying that they just came in and distributed, when in fact guidance counselors said it should have been explained first what reproductive health is and what will be the importance of getting or giving specific contraceptive methods before giving them. Everything should be explained first. So there are many questions actually in that, but when we present papers like this, we're basing on data that we collect. We cannot escape the fact that teenagers really are into this. We cannot say this is not happening anymore. Actually, it's increasing. So that is what we wanted to see. That's why we wanted to know how come it's like this. And we wanted to see the factors that's contributing to this. Many say, oh, there should be which was not found in the study. Raising of both parents should be there for young people because it contributes to sort of a protective factor for them. But then it didn't come out significant. When you control for everything, it's not significant. Even discussion within the home. So, where do we go from there? And every youth, every person is unique. So information that they get may have varied implications in terms of their attitudes and behavior. So that's something we cannot control. So the most important thing is for information to be provided because they will decide themselves anyway.
Okay, started.
Thank you very much for your presentation. The YAP study always presents a very important data. I think whatever perspective you come from or whatever beliefs you have, we have to look at it from the holistic point of view. We look at all angles. My understanding is condom, however controversial you may look at it, it's just looking from one perspective, which is prevention of STIs and early pregnancy. Because early pregnancy, especially in, let's say early 15 to 19 or even younger, has been shown to be associated with not only poor maternal health, but also its impact on the health of the children. Primarily because at that age, the mother is still psychologically not, I mean, not is optimal development. I shouldn't say immature, but not well equipped to deal with issues like this. Not to mention the biological characteristic that if you have an early pregnancy, there's really a higher risk of complication. But having said that, what I would like to ask is, based on this data, maybe it is important to present it to focus groups. When I say focus groups, people coming from different perspectives. I'm talking, for example, of the church. If, for example, maybe our church leaders would think that, they have to talk more about this in the pulpit, with the parish priest talking about what are the disadvantages of having early pregnancy. Or maybe if you talk to of course, social scientist, then they did in terms of education, talk to Department of Health. But what do you think should be the possible avenues for more research to be done? Because I think we can have very good ideas about interventions, but will it actually work? Having data coming from other countries may not necessarily work for the Philippines because of, of course, we have our own unique social-cultural milieu, which is not entirely the same as the other countries. What do you think will be the areas for research that should be done in terms of intervention so that we can actually really, based on evidence, say that this is what should be done in order to bring down the rates of pregnancy or early pregnancy? Thank you.
Actually, there are different mechanisms through which we can introduce information about sexual and reproductive health, not only in terms of the formal education system, but also in the media. But sometimes, I think PAPCOM has tried using the media to influence behavior and attitude of the youth regarding these issues. And also some television stations have introduced the topic as well, and showing the consequences if there are young mothers or young fathers, less than 20, to become fathers and mothers. But then I still believe that given this data, there should be collaboration of different agencies and really discuss how to deal with this, because it's a very important issue that we need to address. And PAPCOM started discussing and training parents as well on how to deal with issues like this. But I don't know to what extent it has been going lately. But they started doing parenting trainings on ASRH before. I don't know if it's still ongoing. But then, young counselors or peer counselors were also tried in the past. Okay? Because some of the youth would rather listen to their peers when they discuss issues like this rather than talking to someone who is older than them or persons of authority like parents or teachers. So where else can we look at? Maybe the church should be involved as well. They should also be advocates of lowering the teenage childbearing and other possible agents of change. Because this is really shocking if you consider that the findings really are teenagers getting into marital unions at a very early age and getting initiated into sexual activities very early, leading to childbearing.
Thank you, Dr. Amelia. So, do you have any other questions for Dr. Hans? Yes?
Good afternoon, doctor. So I'm Glenn from the College of Public Health in Manila. I actually only have a question on one of the results, which is associating uh, getting pregnant during the teenage years and uh, having married or
Facebook. Doon na sa
being
YouTube.
a cohabitation result. So I think
Curious lang
since
ako.
why what GAPS survey is
Minsan, dalawa, tatlo na naman
cross-sectional,
yun.
so
Mga
the
taga-office.
variables are measured in
To check
just
lang.
one time point. We think the
Depende sa,
results
ano,
will
sa kanila
affect
din.
in reasonably that in which case maybe
Doon
the
ata sa,
results of
ano,
getting
sa
pregnant
dashboard.
during the teenage years might have a result on the cohabitation of both individuals. So I think the results for having an odds ratio
Yun sa,
uh,
yun.
for an odds ratio associating teenage pregnancy and
Wala.
cohabitation
Ay.
or marriage, in which this study the dependent variable actually is teenage pregnancy.
Zero
And
na.
then on the other hand, the independent variable we have in this
Recorded
is
naman.
the cohabitation or having married. So I think that result might be questionable. I just want to hear your thoughts about it.
So basically, these are associations and relationships I'm looking at. But then there are some studies like the master's thesis that we have in the institute, and looking at the patterns, the sequencing of events, which one comes first, marriage, sex, and baby, which of these is occurring first and which is next. So this study actually is just looking at associations and controlling for some of these events, other events.
There is a problem actually if you're saying the odds ratio already. Kasi parang it poses a cause and effect relationship already between the variables. So maybe that's just what we need to look into. Also, second question.
There's no cause and effect, just association.
Kasi na-define ko yung variables as dependent and independent. So baka nagkakaroon na talaga ng arrow of causality. So yun lang. Anyway, regarding the survey, do you think there are improvements that will be added into the survey or any variables or elements to the YAPS for the next future surveys para ma-account natin siguro in the next modeling of other variables?
Actually, in previous years, and the last one, the newest module added was about social media, okay, as well as lifestyle. So those are the two additional modules that were added. For the next years, I don't know if it's possible because we have been looking at possibility of doing longitudinal because it's very difficult really to look at the cause and effect if the information is just cross-sectional. So we try, when we look at studies like this, we try to identify proxy variables that can be used as sharing before to be associated with the current status. But then really, if it's the cross-sectional data that you have, then it's really very difficult to have causality in analysis.
Okay, thank you very much. But one last question. Yes, good afternoon, doctor. This is not a question, but I feel that I agree with our doctor from Palawan, Dr. Victoria, regarding doing something other than reproductive health. And being a mother of teenagers, I think we can do something in our own level. So we should be, if each one of us here, parents, will be active in the parents orientation or parents teachers association in our schools, then probably we can talk to them to give us an hour or so to tap somebody who will give a little lecture on these children, because I don't think the teachers would like to do this one or they are an expert on this. But if you can provide us who are the best resource persons for this one, then probably we can, having been a member of a youth organization like the JCI, we can tap them to coordinate if we don't have time, and we just provide the resource speaker. If we do it in our own locality, then probably it can proliferate and we can educate our children.
Thank you. So we are closing this open forum. So we'd like to thank Dr. Onenya for the great talk. So let's give Dr. Onenya a big round of applause. So we're now down to our last speaker, last but not the least, to talk about the mental health. So our next speaker is Dr. Ronald Del Castillo. He is an associate professor of health policy and administration and clinical psychology and behavioral sciences at the UP Manila. He holds a doctorate in clinical psychology from a joint program with the Stanford University School of Medicine. He completed his clinical residency at Harvard Medical School, after which he pursued a postdoctoral fellowship at Tufts University in Boston. Dr. Del Castillo also holds a Master in Public Health from the University of California, Los Angeles. He most recently completed epidemiological research training at the King's College of London. After 24 years in the US, he returned to the Philippines and has since been a professor, a researcher, and an advocate of public mental health. He has been part of the technical working groups in both the Senate and Congress of the newly signed Philippine Mental Health Act. Most recently, he has been involved in video projects for the United Nations Development Program Youth Collab and for Netflix Philippines public service announcement reasons why. Dr. Del Castillo is the principal investigator of the TIWA Mental Health Survey, a project on the mental health of university students. So without further ado, let's put our hands together for our third speaker, Dr. Ronald Del Castillo.
Naghang ba siya? Ay, kala ko naghang siya.
I-blink eh.
Static yung kable niya.
Hang in there, you're going to be all right. All right? Okay, take a deep breath, hold it for 3 seconds, and let it out.
Isa yung connection kayo. Baka sa outlook, hindi siya na yun. Wala ba siyang kopya ng presentation? Meron siyang
Nag-flicker pa. Nag-flicker pa.
Naka-standby yung presentation namin.
Hindi, pwede naman niya isabay. Basahin niya yung notes.
I'm very well aware I'm the last speaker, so we're going to try to go out with a bang. All right? Again, take a deep breath, hold it for 3 seconds, and breathe out. It'll keep you relaxed and awake.
Sabihin ko lang sa kanya na may issue and then iluludo na dito, may clicker naman siya. Ano lang, ito yung clicker niya kanina.
Oo.
So, ikakabit. Dito.
Doon. Kuya, next slide ko na lang kaya.
Kunin mo na lang yung slides.
Hindi, sumabay na lang siya. Sira yung output ng laptop niya.
Good presentation and then
I-load ko.
Yeah. Nagka-copy na ba? Ito na
All right. Are we cool? Right on. All right.
Dito na yan.
All right. Hi. What's up? First of all, thank you for the organizers for inviting me. I love being a psychologist in public health, and I especially love being a psychologist in health policy. I look at making health policy and programming as fundamentally about facilitating behavior change. So when we talk about policies and programs, what we are really talking about are the mechanisms for modifying or influencing the behaviors of others, right? We increase taxes on cigarettes to change smoking behavior. We promote reproductive technologies to improve sexual behavior. So when I look at policies and programs, I have the advantage of looking into their micro-level psychological and behavioral dynamics. For me, this is a significant shortcoming of many policies and programs. The failure to take into account the psychological and mental health dynamics of the people whose behaviors these policies and programs wish to change.
Pag-clinic niya yan. Ito lilipat.
Okay. Okay. Now, why? Because our definition of mental health is fundamentally flawed. We are so quick to make a direct line between mental health and depression, anxiety, illness, and disorders. I cannot tell you how many times I am invited to speak about mental health, but then expected to talk about depression, anxiety, illness, and disorders. And this is where I wonder whether or not the newly signed mental health legislation will truly be transformative. Will it help? Yes. But will it truly transform the mental health care system? I'm not so sure. I've been part of the technical working groups in both the Senate and the House, and I'm currently sitting down in the committee in the GOH to help determine what the Philippine Mental Health Council would look like, as well as the committees that would form the implementing rules and regulations. I know firsthand that the lens through which we have developed the law is fundamentally a misappropriation of mental health broadly and of community-based mental health in particular. Now, would the law give greater access to to mental health care at the local level? Yes, absolutely. Will it provide for more health insurance coverage? Absolutely. Will it offer more resources for our local schools in promoting and protecting the mental well-being of our students? Absolutely. It will do all of that. But community-based mental health is not about putting more psychiatrists, psychologists, social workers, and other mental health professionals in the local community. Yes, we need them in the local community, but this is not what community mental health means. It is not about improving access to medication or talk therapy. Yes, we need to reduce the barriers, especially financially, to evidence-informed treatment, but this is not what community-based mental health means. It is not about outpatient psychiatric treatment instead of institutional care. It is way more than that. Okay? Now, the traditional illness models, I won't belabor this point, is something is wrong with you, let's fix it, here's medication, here's talk therapy. Now, ameliorative change, this is what we might call first order change, this is where I think the current mental health legislation is, and where we are moving towards with implementing rules and regulations. Ameliorative change involves changing the system, yes. But where it falls short is that in ameliorative change, we do not question the fundamental values of the system or the assumption about how it should operate. There is still very much a power imbalance with experts on one side and with service users and their families on the other side. And what I am encouraging us is to move towards transformative change. And this is where community mental health lies. Actual community mental health lies. So the law says it is community-based. It is not. Remember, ameliorative change is first-order change. Transformative change is second-order change because it involves a fundamental change in the values and operations of the system. Where ameliorative change is about improving the individual and maybe some programs and policies, transformative change is about rooted in an ecological approach between service users and other stakeholders, most especially professionals. So, when the new law offers us an opportunity to send a mental health professional to the barangay health office, what we are merely doing is transferring mental health care to the local level without fundamentally changing the relationship between the service user and the psychiatrist. And I know this firsthand. So, a few years ago, in 2014, I spent 3 months in Iloilo and Negros and Ilonggo. And I grew up in Iloilo before we moved to the US. I was doing field work and evaluating the mental health care system through a human rights lens framework. So I spent 3 months there and interviewed about 90 people across the different layers of the mental health care system. So psychiatrists, psychologists, service users, their families, deans of medical schools, physicians, municipal health officers, barangay health workers, so forth and so on. And Region 6 was, and is, experiencing a lot of the challenges faced by other regions in the country. And I won't belabor this point because you know this. This is a story that is very familiar to us, right? Not enough mental health professionals, poor access or availability of treatment, poor conditions in hospitals and clinics, mental health is a low priority, it is neglected, blah, blah, blah. There's widespread stigma and discrimination, blah, blah, blah. We know this story, right? We know this story very well. And so let me illustrate a point here, okay? The government believes that people with mental health problems, are useless, not worth it. They believe that something is wrong with that person, that they have no right to live their life to the fullest. This is based on an interview I had with a social worker who worked for the DSW outside of Iloilo. Another came from a mother, and she said, when people hear that you have a special needs child, people think you are not useful, not worth it. Why would you spend money when you get nothing in return? That's the thinking. Why send her to school? Why spend so much when in the end it will be useless? It will be worthless. It's very painful to hear. And her child, I interviewed her, and her child had Down syndrome. And finally, I have one politician patient. I asked him, help us with mental health and the people with mental illness. You know what he said? he said, but they don't vote. Now, we know this story. We know this story. We've heard this story before. So, while service users and families reported that treatment, including psychiatric medication, was helpful, the majority had limited understanding about the nature of their treatment. The overwhelming number of service users did not know what medication they were taking and why they were taking it. Some were told it was for sleep, or were told that the psychiatric drugs were vitamins. Mental health professionals corroborated that this was common practice, that this was a common explanation of the medication, that it was vitamins. So most of the service users were not given an explanation of the potential side effects of the medication. And if you know psychiatric drugs have a lot of side effects, right? Some did not know why they were brought in the inpatient unit, did not know how long they would be there, and did not know whether or not they could leave. And most critically, many were not informed that they had the option of declining treatment. Now, most of the service users could not specifically describe their psychiatric diagnosis. Many service users reported that healthcare providers did not provide an explanation of their symptoms, and when an explanation was provided, some service users reported that it was not consistent with their experience. Imagine, your diagnosis is one thing, but your internal experience is something else. Now, most service users also were not included in the decision-making process of the inpatient admission. Although some expressed a wish to improve